With an increased use of extended criteria donor, reconditioning has come back on at the forefront of transplantation. But before we start thinking when to apply reconditioning, I think it's important to understand what we mean by it. A quick look at the dictionaries will tell you what reconditioning means, essentially restoring something to good order. Furthermore, the American option gives you some suggestion of how this may be achieved. Reconditioning implies that the damage has already been done, and therefore any intervention should revert the effect of that event. However, in the deceased donation, we have the ability to try the treatment before the event has occurred, before the damage has occurred, particularly in the scenario of DCD. The goal should be simple, essentially maintain and improve the organ function. And because it's in the donor, we need to protect all organs from subsequent injury or pre-existent injury, ultimately leading to an increased organ utilization and recovery. However, the targets are different because the mode of death is different, and DBD is an absolute event, catastrophic event at cellular metabolic level, which has lasting effects, whilst the DCD has got a different mode of injury with dual temperature ischemia, but with a very short window of applicability. And this is illustrated by this study, which looked at the cytokine expression between DCD, a living donor, and DPD. And as you can see, the DBD is a massive storm of cytokine release, of which some of them could be potential targets for intervention. But there are many challenges, particularly if we're looking at the in situ reconditioning. Most of the strategies tried so far are organ-specific, but inevitably they will affect all organs. We still to define the duration, the timing of intervention, and also the method of intervention. Now, of course, donor management has been around for some time, and in fact, through generic interventions trying to revert the effect of brainstem death, we have achieved a significant increase in the number of organs we recovered. But it was recognized quite early that all those interventions had a minimal effect, positive effect on the organ function. And therefore, really we need to shift from the donor maintenance to therapeutic interventions which may reverse the process of death effect and also prevent ischemia reperfusion injury. We take a pause for a second because most of the interventions, particularly in the donor, are associated with significant challenges, and some of the challenges are shown on this slide, and it's got a tall order to try and implement this routinely into practice. So what have we got so far? Broadly speaking, there are two generic strategies that have been employed, and I'm going to talk a little bit about pharmacological intervention first. The strategies that made it to clinical practice, to human trials, are based on the traditional approaches from donor management. But none of them has really made any positive effect, if any, on the outcomes of all the transplants. An alternative strategy was to use sevoflurane. And in this study, donors, DBD donors were given sevoflurane prior to circulatory arrest. And it was interesting to note that the livers transplanted from these donors that were preconditioned with sevoflurane exhibited a significant reduction in early allograft dysfunction and also a lesser ischemic injury as judged by the levels of transaminases. But here's the interesting thing. When the same approach was tried administering sevoflurane in the recipient prior to reperfusion, there was no effect. As I mentioned, we need to move away from the traditional concept to a little bit more novel target, which should look at the pathways that now we are beginning to understand a bit better. There are numerous studies, too many to cover in such a short time, but I'm going to focus on 4 strategies that I think may have an impact and translate into clinical practice soon. We now know that the lack of oxygen leads to HIF activation. And this study looked at pharmacological HIF induction with a prolyl hydroxylation inhibitor, domain inhibitor, which was administered 6 hours prior to retrieval of the kidneys. What this study showed is that it stabilized the HIF levels in the kidney and led to a rapid activation of the target genes. This study is important for two reasons. There's two critical issues here that they were identified. First of all, the activation of the target genes occurred quite early, within 2 hours of administration. Secondly, is that the effect was stable throughout the cold preservation phase, and this was a prerequisite for subsequent potential protective effect during reperfusion. On a clinical level, this is a study that actually showed for the first time that there is a significant correlation between an early intervention to address the damage and the long-term outcome, shown here by a reduction in DGF and a better survival in the black lines. Carbon monoxide administration has been shown in many models to have a protective effect. This study looked at effect on ischemia reperfusion injury in liver, and did so in two ways. First of all, in in vitro model, the authors showed that carbon monoxide exposure reduced the ROS generation in the Kupffer cells and increased the expression of heat shock protein 70. Then they moved to an in vivo model, and they showed that exposure of the donor to the carbon monoxide followed by cold storage led to a significant recovery of the livers with reduction of ischemia reperfusion injury, better liver enzymes, and less inflammation. Brain stem death affects complement activation. And in fact, complement inhibitors are currently in trials in the recipient, but this study looked at a much earlier administration. So several doses of complement 1 inhibitor were administered within half an hour of brain stem death, and the effects were measured 4 hours later. What the authors showed is that there is a dose-dependent effect with a reduction of the complement and an increased functional level demonstrated by a reduction in the creatinine. And finally, the fourth strategy that I wanted to talk to you about was the use of mesenchymal stem cells, and this has received quite a lot of airtime recently. And in this model of deceased donation for lungs, donors were exposed to bone marrow recipient-derived mesenchymal stem cells administered either intravascularly or endobronchially. The endobronchial administration led to a better oxygenation of the lungs in the top panel and a reduction in the vascular resistance in the bottom one. No matter how interesting that is, though, it's quite difficult to see how we're going to translate this in clinic when we need to have the derivation of recipient bone marrow stem cells prior to donation. So although the pharmacological strategies hold enough promise, I think it's still the physical ones that have made it to the clinic so far. Ischemic preconditioning has really not lived up to the expectation, because in this meta-analysis, it clearly showed that it has no beneficial effect on the liver, on any of the markers of injury in the liver or the outcome. But more importantly, pooled data from the two studies looking at ischemic preconditioning show that the remote effect on the kidney may actually be a detrimental one, because it showed an increase in delayed graft function and graft loss. More importantly, there is a bit of a concern about the long-term effects of ischemic preconditioning, and this study, looking at hepatocyte transplantation, really showed that there is an altered antioxidant enzyme and lipid peroxidase content, and more importantly, there appears to be oxidative DNA damage, shown by the deposition of 8-oxo 2-deoxy a DNA adduct in the hepatocytes nuclei, shown in the top right-hand panel. So if that doesn't work, what else can you do? Well, hypothermia has now been looked at as a potential protective model. In 2009, this Finnish group of intensivists proposed that a small reduction in the temperature, in the core temperature, may lead to a substantial reduction in the metabolic rate associated with a lower consumption of energy substrate, which could partially suspend the activation of the cell injury. This was then correlated with some mechanistic work, and the apoptosis appears to be suppressed. And particularly the key player that we now know it's involved, the mitochondria, appears to be involved. And in fact, a recent study showed that mild hypothermia does improve mitochondrial function. In this particular study, warm ischemia was induced with a significant hemorrhagic shock, followed by preservation at 3 different temperatures. What the study showed is that mild hypothermia restores the ATP, prevents the histological injury, and restores the mitochondrial function by improving the membrane potential. And if you remember yesterday's talk, the same key temperature comes on again, 32 degrees. This was taken then on to clinical trial, where donor core temperature was allowed to drift slowly by 1 or 2 degrees. And what this study showed, that there is a significant reduction in DGF. But critically important, it appears that the most beneficial effect actually happens in the extended criteria donors. However, the effect on all the other organs has not yet been reported. Perhaps the most significant development in the field of in situ organ reconditioning is the introduction of normothermic regional perfusion in DCDs. This is now used in many countries in Europe, as demonstrated by the number of abstracts submitted at this conference. And although the surgical approach is well established, there are some differences with regards to clinical application across Europe, and these are the key factors. For me, the most interesting one, in light of the discussions we just had about hypothermia, is whether or not there is a need for heat exchanger, and whether or not you can allow the donor to drift slightly to a lower temperature. First of all, NRP has been shown to increase the organ recovery rates. And although there is a bit of variation in this reported studies, all of them are above what's been recovered from the DCDs in their respective countries. But most recent experience from the 2 UK centres involved in NRP, Edinburgh and Cambridge, show that with increased experience and understanding of the procedure, you can actually continue to improve the recovery rates. The key question is, how much do the organs from a DCD donor can improve with NRP? And this study from Spain, from the Santander group, hints to the potential of recovery towards the DBD level. And they've seen this in a small series, but they've seen this in both kidney and liver. So of all the interventions that I presented to you so far, this appears to have a significant effect across all organs. And if we look at the liver first, there's a significant reduction in the ischemic reperfusion injury. But clinically more important, there is a substantial reduction in the incidence of ischemic cholangiopathy. And this is pooled data from the 2 UK abstracts presented at this conference, where we've seen a dramatic reduction in ischemic cholangiopathy rates. Similar effects were noted in kidney, and this is French experience in uncontrolled DCD donation, where first of all, they've shown that NRP, the use of NRP, is associated with a significant reduction in DGF. And again, it's the only predictive factor for a better kidney function at 1 year, as defined by a GFR of over 40 mils per minute. On a more recent presentation from the French group, this time comparing the NRP kidneys with DBD, similar results were shown. Massive group of DBD comparison, but here is the factor, that DCD NRP has a much lower delay graft function with a comparable GFR at the time of discharge. This positive results encourage the expansion of the criteria utilization, and this study from the Oleg Resnik's group from St. Petersburg showed that in fact NRP can probably abrogate the detrimental effect of fairly prolonged warm ischemic time, achieving comparable results at the end of 1 year with DBD. And again, they're presenting their 5-year updates at this conference. But perhaps the most interesting thing looking at the ability of NRP to recondition comes from the Italian experience, again presented at this meeting, where in the DCD setting there's a legal requirement of 20 minutes of no-touch period. Inevitably, this leads to a significant prolongation of warm ischemic time. Despite that, the Milan group were able to recover 7 livers, transplanted with excellent results, no detrimental effect, and 100% survival quite early. So we know clinically it works, but we need to understand how it does so now. And some of the data from the Barcelona and Cambridge group showed that NRP does restore ATP. Also increases the levels of endogenous antioxidants, reducing the reperfusion injury. Our group was interested in the HIF activation, and I'm revisiting the story that I presented earlier on. So in an abstract later on in the conference, we'll show that within a short period of NRP, 2 hours, there is activation of HIF pathway with a significant upregulation of some of the target genes, which may explain some of the reconditioning effects of the NRP. The key for any reconditioning is how to assess the effects, and everything that I presented so far, apart from NRP, can only be assessed post-transplantation, but NRP does provide with a diagnostic window. And although so far we relied on traditional biochemical markers, albeit in a dynamic function, we need to think differently soon. If we look at the criteria used for assessing the graft, they're same across all programs, although with some interpretation differences. What this tells us is that we still to learn what this means, whether there have any benefit in terms of assessing the graft. So perhaps we need to think differently, and our approach was to think about a metabolic assessment of the graft. In a porcine model of DCD donation with 45 minutes of worm ischemic time followed by 2 hours of NRP, we use NMR spectroscopy to detect changes in different metabolites. And what we are able to show quite early is that between different time points of experiments, ischemic and then reperfusion, there is a different expression of these metabolites. The problem is NMR is a bulky technology, it's not available at bedside. So really our interest is in developing a portable device that can assess all those changes in real time. So in summary, we've seen several encouraging results from a variety of interventions. There's no question that donor reconditioning or interventions in the donor remain the final frontier, but do offer a tremendous potential for improving quality. So far, from a clinical point of view, the biggest improvement has been seen in the DCD, where NRP results have been encouraging and offer the potential for further improvement of the graft. Therefore, I would put to you that organ modulation should and can start in the donor. But in the light of the challenges that we've alluded to, in order to implement that clinically, we need significant leadership from the professional bodies, increased resources, and really an engagement of the entire community to achieve this utmost priority of improving donor organ quality. I'd like to thank some of my collaborators and clinical colleagues who have made possible the generation of some of the data that I presented today. Thank you.